Good morning. Thank you for waiting for what I hope will be an interesting session, but of course I won't be the judge of that. This session came about through sitting in innumerable MDTs with an increasing prevalence of referrals of incidental findings in more frail elderly people. And this brings with it a challenge in making decisions on when is it right to treat a lot of conditions with which we're presented, when is it right for us and when is it right for the patient. And they're challenging decisions that seem to be becoming much more prevalent as time goes on. And I hope that by the end of this morning we'll have more of an insight in some of the factors involved in making those decisions, but patient-centric. I thought the session yesterday that was promoted by the section of oncology was a really interesting insight into assessment of the frail elderly, and we may touch on some of that in this session. We have if you ignore the first person, we have an expert faculty to present to you. I'm a urologist in Leeds. We have Professor David Walker, who's a consultant in intensive care, and will talk to us about assessment of frailty and how we can make decisions over the impact of that on treatment. Harry has a fantastic patient story to share with us, and Dr. Angela Coulter will give us some insight into how patients make decisions and information that they may choose to derive to help them with that decision making. So let's start with a quiz. If you switch on your smartphones and get to the voting bit, I'll leave that on for a second for you to see how to do it. I don't believe you can be identified from your answer, so vote honestly. I'm happy to make an assessment on the life expectancy of my patient and to discuss this openly with them and their family when planning treatment. Make your decision. Are there no orthopedic surgeons in the room? We don't have anybody answering D. So an interesting spread. I think we learn from that there is an opportunity to share some tips and tricks. But I'd like to start by telling you Maurice's story. And this is a patient that I've been treating for a number of years, and Maurice has given his consent for me to share this story. He was originally going to come to this meeting and talk with you about how he'd made some difficult healthcare decisions. He's a very eloquent man. He spent most of his life making difficult decisions in his profession. He's a very eloquent, well-spoken, literate man, albeit from humble background. And I know it's not usual to start a story with the end of the story, but sadly Maurice died a few weeks ago, and that's why he's not here to share some of the difficult decision-making times in his life. So he first came across urologists in 2005 when he presented to a colleague with hematuria and went through the standard assessment at that time, and nothing abnormal was diagnosed apart from a large prostate. In 2012, he presented with a cough, had a chest x-ray which showed a bulky hilum, and it subsequently led to a CT scan. The chest was clear, but he'd got bilateral renal tumours. At that time he was fit, his mobility was limited by osteoarthritis, and he had type 2 diabetes. So we embarked on a treatment plan that started with a left-sided lap nephrectomy and adrenalectomy, uncomplicated procedure, took out a PT3A tumour, and his renal function dropped as anticipated. At this time, he had no difficulty at all in consenting to complex surgery. He understood the risks, the benefits, and he understood the specific risk that he could end up on long-term dialysis. We made a treatment plan for 6 weeks later and took out his right-sided tumour with an open partial nephrectomy. This was margin clear. Bit of a longer post-operative stay for the open procedure. He went into retention, had a long-term catheter fitted, and decided that actually he'd had enough of surgery for a while and he'd keep his catheter. His EGFR fell a little bit to 30. That was in 2012 when he was in his 70s, and we followed him up through our routine pathway. And in 2016, at the age of 80, he presented with a recurrence or a new tumour in his right kidney. We felt this was his only disease at the time, and he underwent cryotherapy. Even though he was older, he had no new comorbidities apart from his long-term catheter that he was still content with, and he elected again a treatment with curative intent under general anaesthetic. He understood the risks of a possible further loss in EGFR as well as complications of treatment, but was fortunate to have an uncomplicated stay and went back into routine follow-up. During that routine follow-up last year, we detected a recurrence in his right adrenal gland. His original left-sided radical nephrectomy had taken his adrenal, and treating this solitary metastasis would render him without adrenal glands and the need for adrenal replacement therapy. His comorbidities were the same, but he was a much more frail man. He remained very articulate, and this was a film he made for the local television at the time, regaling lots of interesting stories from his long career. He remained a very articulate speaker who could make sharp, careful decisions. And Maurice decided that treatment for him would be wrong. He didn't want the risk associated with further surgery at this time. He was 82. He didn't want the complexities of adrenal replacement therapy. He was content to follow the natural course of his life and the quality of life that he had. And what struck me was how quickly he made that decision, how firmly he made that decision, but also how his daughter that was with him was involved in that decision and how they could talk with each other openly about effectively not accepting potentially curative treatment. How they accepted that the decision he made would be about quality of life and not about length of life. And he describes a lifetime of making complex decisions, about dropping star players from England teams, about being aware that he didn't have a squad of players strong enough to beat the Australians and telling his bosses that they would lose 3 consecutive test matches because England were not strong enough, and making hard decisions around that. And he equated the decision on his healthcare as a similar thing. He made a decision, he stood by it, and it was right for him. But impressively was his communication with me, with his daughter, and the openness with which he could talk with us. Sadly, he became more unwell in the subsequent weeks, and he passed away of a complicated chest infection, having spent his remaining months at home. So unfortunately, Maurice couldn't be here to share this, his story. We do have a wonderful patient interview to come from Harry, but what I'd like to hear now is from our next speaker on the complexities that we have in making a judgment on whether it's right to treat and how we can work that out.
Good morning, everybody. Firstly, thanks to BAUS for inviting me north to give this talk this morning. New audience, urologists, another group I can offend and leave and never be invited back, but hopefully you'll see some commonality in what I'm talking about this morning and recognize that it's a team event. I work here, I do intensive care medicine. I have an interest in the high-risk surgical patient. The university pays my salary for going around the country talking about the thing I'm going to talk about most, which is perioperative medicine and high-risk surgery and perioperative medicine teams. The brief was optimization. Enigmatically, I called my talk optimization and a few other things because I'm often asked by surgical colleagues, some of them in the room I can see before me, can you just see this guy in clinic and optimize him prior to surgery? So we will talk a bit about optimization, but I thought it was a great opportunity to just broaden discussion, to talk about a couple of elephants in the room and a model that might make a difference to some of your patients. Start by a fact. You're 1,000 times more likely to die in the 30 days after surgery than you are during surgery or in the perioperative period. Everything I hear about is about the surgery, getting him fit for surgery. For me, the starting point is to recognize your patient, your high-risk patient, is far more exposed in the days following surgery than during surgery. And the population's getting older, of course. I've taken this from the Daily Telegraph 2014 and was amused to see that the Queen had taken on 2 new staff in her telegrams department, this to meet the need of 14,000 centenarians in the UK in 2014, a 70% increase in just 10 years. And here's our work then, a dated slide from the King's Fund. Graph on the left, you can see that the aging population, the booming population in our society are those over the age of 85, and not surprisingly, perhaps the middle columns tell us that our emergency worker has gone up significantly during that time. But look to the right, and you'll see the amount of elective work rising 300% in just a decade. And for me, elective work in the NHS talks a lot about surgery. So somebody out there in the audience is looking after this population of patients, and it's growing. A few words about surgery then. 250 million surgeries a year in the world, 10 million of them taking place in the UK, and that accounts for, by and large, 20,000 UK perioperative medicine deaths per year. 15% of the 10 million surgeries that take place in this country per year take place in something called the high-risk surgical population. And we'll talk a little bit about more about those in a second. Although they only make up 15% of the 10 million, they account for 80% of the deaths. The sad facts are we're able to characterize this population, but we often fail to do so. Anybody in the audience who doesn't know what an old, or rather what a at-risk patient looks like, it looks like this. It's a patient who's usually older, more infirm, and is seeking big surgery for a cure for cancer. And this is my big data slide. Australia, Melbourne, David Story's group followed a group prospectively of patients over the age of 70, having predominantly intracavity surgery, following them up for 30 days, mainly ASA3 grade patients. And he found that by day 5, 1 in 5 patients had sustained a major complication. By day 5, 1 in 10 of them were in an HDU stroke ITU bed. And by day 30, 1 in 20, 5% of those patients were dead. No surprise then, big features in that were age, comorbidity, and the usual suspects of diseases which you're all very familiar with. Coming back to the UK then, 2011 CPOD data, 14,000 deaths. It shows you in the column on the right-hand side the sorts of characteristics that patients die with, not necessarily of. And none of that will be any surprises to you. A preponderance of respiratory diseases, arrhythmias and diabetes, and down right at the top there, congestive heart failure and cirrhotic disease. That will be no surprise to anybody in the audience. So it's important then to recognize that heart failure in our society has grown in incidence by 12% in the last 10 years. As a consequence of the aging population, its prevalence has gone up by 23%. The important thing here is that the incidence of heart failure is equal to the incidence of all 4 combined top cancers in the UK. And this is what we're playing out our surgery, our anesthesia, and our intensive care against, the shifting sands of our population. This made me smile. I've taken this from the Isle of Wight Gazette. I get asked by people to optimize patients. Here, Britain's oldest lady, hip fracture replacement at age 112. The family say that it's given her a new lease of life. And I can believe it probably has. But I'd ask you to put yourself in my shoes and wonder what optimization you want from me prior to going ahead and conducting elective surgery in this deserving, high-risk population of patients. I'm talking predominantly to a group of surgeons, and I know what you think of surgical pre-assessment. It's just a way of delaying surgery, the main event. It's a series of processes. It's a swab up the nose for MRSA. It's a little handout to tell you not to drive after you've had an operation, and it's to be sure you've got a group and save. Interestingly, if you do a clinic, I consider it to be an exercise in public health. Many of your patients will never seek medical opinions for anything. They've probably only ended up on your list because they've developed hematuria. But by and large, they skirt medical opinion. They don't get their blood pressure checked. They avoid any interactions with doctors. And for me, seeing a patient prior to surgery is often an opportunity for me to treat blood pressures, to link with GPs about smoking, alcohol abuse, and those sorts of things. Something I never thought I would be involved in. I think, if anything, surgical pre-assessment is a good public health intervention. But I think what we have to recognize is medicine's getting really tough out there. I mean, diabetes galvanizes both the opinions of surgeons and anaesthetists. You will know the risks associated with operating on a diabetic patient, the risk of respiratory failure, surgical wound infections, UTIs, and cardiac disease makes the diabetic patient an archetypal high-risk surgical patient. Back in the day, you're having an operation and you're a diabetic, the surgeon would stop your metformin in clinic. An hour before surgery, a nurse would prick your finger and test your blood sugar. And when nobody was looking, an anaesthetist would give a little bit of insulin under the table to just make the numbers better, and the patient would go home. Today, a 56-page document just tells us how we should be managing diabetes in the perioperative period. Importantly now, things have moved on to such an extent and to such a complexity that this has become a specialty of its own. Be sure you know what you're doing with your DPP-4 inhibitors or your GLP analogs next time you see a diabetic patient. Whatever you think of surgical pre-assessment clinic, the table at the bottom tells the story. The two groups, left and right, are those who engaged with surgical pre-assessment clinic and those who did not. And for expedited, urgent, and elective surgery across the board, if your patient engaged with a surgical pre-assessment clinic, your outcome was better. Move now to the table above it, and by definition, a high-risk population. In 2011, only 4 out of 5 of those patients managed to find their way to a surgical pre-assessment clinic. I think that slide is probably dated now, and I suspect that number has significantly improved. And not just retrospective registry data here, prospectively, John Carlisle in the West Country, colorectal cancer, shows a Kaplan-Meier curve that on the top shows a group of patients who were engaged in surgical pre-assessment clinic, and those in green below those dying more readily, not having been engaged in surgical pre-assessment. But it's complex, and it isn't just about optimization, I would argue. It's about risk stratification. It's about talking to patients, and hopefully we'll understand a little bit more about what I mean by that shortly. And it's about the allocation of surgical resources and anesthetic resources. I took a photograph of a set of notes a couple of weeks ago. The top set, the very top set, is the surgical notes, and below it what I spent all of my life doing, flicking through medical notes and trying to reconcile what is the best pathway, the safest way through for your surgical patients to get an operation. That's the reality of my surgical pre-assessment clinic. The future of optimization, before I move on then, may be about individualized risk. Whether CPET is something you do in your own institution. We have a lot of CPET going on at University College London. Our outcomes with CPET and urology patients is difficult to assess at the moment, and we're not giving you any pointers towards personalized risk. We do surgical school. We cohort patients together with cancer. We bring them in, and we make them proactive, active participants in their cancer disease. They get to learn about pre-assessment, pre-rehabilitation, and stopping smoking, and all of those sorts of things. And we have a very strong enhanced recovery program at UCLH. And I think optimization is probably today more about those sorts of things for the future than it is about changing medicines. With that in mind then, I'd just like to introduce you to a real patient. He's 84, his name was Jim. He's got a BMI of 17, he lives alone, he's lost his appetite and his balance and his confidence too. He had a coronary artery bypass graft in 2004, and he's now seen in the heart failure clinic every 6 months. He's got sarcoid, he's got hypertension, and he lost his wife 9 months ago. The heart failure team investigated why he had anemia, and they found a cause, and he needs a nephrectomy. At last, we have a diagnosis with a treatment option, something we can really do. And in medicine, we do just that. Everything that defines this guy, that heart failure, the diabetes, the living alone, the personal isolation, gets squeezed into a footnote in the medical notes, because now we've got a treatment option. We've got a nephrectomy and a promise of a better day tomorrow. The psychologists call it the imperative of possibility. Doctors trained in the scientific method find it difficult not to treat, particularly where there is an evidence base which shows that treatment X shows some evidence for better outcome. We wrote this about 3 or 4 years ago in the BJA. I wish I'd changed the title to Advanced Care Planning, because end-of-life decision planning to me sounded like a patient who was in the last days and weeks of life. But of course that isn't true. End of life, according to the GMC, is any patient within the last year of life. And GMC also tells us what our obligation is to that patient, is to have meaningful discussions, not about CPR particularly, or whether you'd want to be on a kidney machine, but really just generally, what are they seeking from treatment, what are the options, and how we as a medical profession can help facilitate those sorts of things. And we asked, at some of the pre-assessment episodes we saw and surgical visits we sat in on, we wondered gently whether there was an elephant in the room for much of what we were listening to. What you want to know is, who is it sitting before you who's going to die in a year? That's really difficult, and perhaps Angela will help us with some of that this morning. Risk stratification is difficult in your population of patients. It's about validating risk scores, and that's really difficult. Whatever score you use, I think it's important to recognize that if a patient undergoes a surgery where there is a risk, where there's a documented risk, your outcome at any stage of your surgical intervention, including mortality, is better at every stage. Something about the act of risk prediction and discussing risk with patients improves outcomes. And I don't want to tell you which to be using and how to be using them in your population of patients, but if you don't know anything about frailty and delirium, it's time to catch on to those. These are our diseases of the future. And maybe all JS needed to know about his nephrectomy was his chance, being frail as he was, that he has a 50% less chance of being alive at 1 year than his non-frail colleague. These are the things at 84 and to Jim which might make a big difference. Here's a surgical paper. It reminds us why complications are a disaster. Complications must be avoided at all costs. I can tell you what the complication rate is for major surgery across the world. It's between 15 and 20%, and that number does not budge. It's a constant. You can point to any paper you want, any big registry, any prospective data. Major complications after high-risk surgery is 20%. And here, Curie surgery, Annals of Surgery 2005, demonstrates what happens to the Kaplan-Meier curve of a patient who receives no complications at the top and complications below it. At 1,000, 2,000, 3,000 days after surgery, your chance of dying is statistically higher. Now, I know what you think. My patient gets operated on, he gets a pneumonia, he goes to the intensive care, he gets renal failure, he goes on a filter. Guess what? 3,000 days after surgery, yes, of course, he is going to more likely die. But look at the graph to the right of that. Simple wound infections, 1, 2, 3,000 days after surgery. Curie tells us that your chance of survival is significantly lower. My favorite paper then, a surgical paper, New England Journal, 2011. Hospitals split into quintiles. The quintile is on their hospital mortality from low-risk hospitals on the left, going through to higher risk of death at the end of that quintile. And Gaffari looked at complication rates in surgical patients. And to his surprise, he found no statistical difference between the complication rates, which were about 16%, in the lowest risk hospital of death and the highest risk hospital of death. In the middle, even when he stratified for major complications, there was no statistical difference. Move to the right-hand side, the difference was, of course, the mortality difference associated with having a complication and surviving your complication. And the term failure to rescue. It isn't complications that kill you, it's the failure to fix those complications when they occur. Gowandi, another surgeon, in his TED talk, talks about the evolution of surgical practice, winding back to the start of the 20th century. He said surgeons were lone rangers, out there doing their stuff, crafting their own techniques, being resilient, being self-sufficient. They managed patients alone from start to finish. Wind forward 150 years, and what have you got? A surgical episode which looks much more like a Formula One team, where everybody brings something special and something different to look after that population. And for me, this is key. Perioperative medicine, surgery has become, in a high-risk population, a team event. This, for me, is not about surgery and consult medicine. This is about team perioperative care. I'll leave you with a final thought. It comes from a professor of business at Harvard, Theodore Levitt. He wrote a paper on the downfall of the American railroads. In his paper, he said the bosses of the railroad companies defined themselves as being in the railroad business. And what he really should have been doing, they should have been defining themselves about being in the transport business. While they were busy developing rails, everybody around them was developing the motor car, roads, and commercialization of air travel. They demised because they defined themselves too narrowly. And I thought about this for surgery, anesthesia, and perioperative care. He said, sustained growth depends on how broadly you define your business and how carefully you gauge your customers' needs. I would argue things have changed about how we look after the high-risk surgical patients. We must not define ourselves as surgeons. Anaesthetists must not shrink back to the anaesthetic room and say, I give anaesthetics. We must be out there looking after patients from the day they're admitted to the day they're discharged. So in summary, optimization takes place on the shifting sands of comorbid aging population who seek cure from advanced surgical techniques on a limited budget where expectations in society remain high. The pre-assessment clinic, whether you think it's an opportunity to tick a box or a public health intervention, the facts remain that if your patient goes to a surgical pre-assessment clinic, he will do better than those who do not. Complications must be avoided, and I think the answer to avoiding complications is a perioperative medicine team. And finally, and setting the scene perhaps for the next discussion, better conversations with patients about what they seek from this episode of surgery may be revealing to all of us. It's not an act of rationing for patients. This is about understanding what matters to them. And that's the most important thing. Thank you.
If we have time at the end, we'll take some questions from the microphone, but if that's okay, we'll just carry on with the next speaker.
Thank you, David. That was an absolutely fantastic talk and nicely links into what I've got to say and I think what Angela will have to say. So first of all, good morning. It's a real privilege to be here and to be sharing the stage with such a fantastic panel. It's great to see so many of you here early and bright and enthusiastic after last night's extensive social program, so that's good. Now look, I think we all know that the rapid advances that we've seen in surgical practice have really afforded us a huge range of options for treating our patients. As David says, even those who might have previously been considered unsuitable for intervention. But is offering surgery always the right approach? We know it isn't. And as surgeons, although we're pretty good at discussing the pros and cons of our procedures, we're even good at assimilating evidence, but are we good at considering other factors that are important to patients? We do find it really hard to talk to patients about choosing not to operate. The purpose of my session is really to kind of give prominence to the patient view. And I'm going to present in a minute this chap's, Brian, my patient's story. So he's 83, he's a really fit 83, and he presented, this video's not running, he presented with a small renal mass. Incidentally, he's a victim of modern imaging technology. He is fit and active, but he's a sole carer for a very frail wife. He initially had a discussion about this little tumor and he opted to watch and wait. And we did that for 1.5 years, but over the course of that time, the mass was enlarging. And this led to Brian, in summer of last year, electing to have a biopsy, which showed that it was a renal cell cancer. Now, most of you know me, I'm no expert in renal cancer, so I sent him off to Gominda Mann, my colleague, who had a discussion about all the various options for the management of his small renal mass, but he opted to continue surveillance and he wanted to come back and see me and talk about it again. And I found this really interesting because Brian is fit and on the surface of it would have been fit, unlike John's patient who clearly had a lot else going on. But despite that, he chose to continue to pursue a non-operative approach. So the focus of this video is really about what informed that decision and what we can learn from it. So I've talked long enough. I'm going to hand over to Brian. I apologize for the now the video runs, fantastic. I'll hand over to Brian just to mention, to put it into context, this is not a man who's scared of surgery. In the time that I was seeing him, he had a series of unfortunate events. He had an incarcerated hernia, which needed a surgical approach. He also developed really nasty malignant melanoma on his face, which needed major oncoplastic surgery. So, this is a man that is quite clearly happy to have surgery when he needs to. So these are the kind of questions I explored with him, and I hope I've managed to bring those out in this video. It's about 6 minutes long, it's not very long, but I hope it does bring out some of these key points. So without further ado, and praying that the technology works, let's have a look. Brian, thank you for coming along. I think you and I first met at the beginning of 2017.
We did, yes.
Because so what's going on there, sorry? Brian, thank you for coming along. I think you and I first met at... Brian, thank you for coming along. I think you and I first met at the beginning of 2017.
We did, yes.
Because you'd had a scan which showed a little lump on your kidney. First of all, can you tell me, how did it feel kind of living with that uncertainty of having a potentially serious thing?
Initially, it was very strange, and you suddenly thought, wow, I've got cancer. Maybe it may turn out to be that. But it didn't particularly bother me, because we knew that probably if it was the worst, then we could sort it out. That was my view anyway, and I was pretty fit anyway. But I've got other things going on in my life that meant that my mind was taken off it. So it was not a big deal.
So you and I had some, I think it's fair to say, fairly frank discussions
yes, you didn't hide anything.
I think I told you quite explicitly about the risk of the cancer growing and spreading.
You did.
And the risk of you even dying from
absolutely.
it. And I mean, how do you feel about having that
level of information, that much information about life expectancy, did you feel comfortable discussing that?
Yes, any time prior to getting that information, I felt that I would virtually close the book and I'm finished and that's it. But it wasn't like that at all. Somehow or other, it was something that could be dealt with, but it wasn't important, it wasn't urgent, there were other things going on, and let's just park it and forget about it, knowing full well that I'd got you behind me, and if we needed to go further, you've got some good guys behind you as well. You could have hidden it, buttered it up, and I'd have been living under a misapprehension. You told me the bottom line, and that I appreciated. I went out absolutely stunned, but within a few days I was back
on your feet. How do you feel information ought to be conveyed, especially when it's serious stuff like that?
The written information has been incredibly important. You get to an age where you don't remember what happened yesterday, so you do need that bit of paper, and you come across terminology that you don't understand and you forget within 5 minutes of being told. The bit of paper proves that you've got a record and you can relate back to it. I think that's desperately important.
Okay. I mean, having considered all the information, you obviously decided to pursue a watchful waiting strategy, and we ended up doing a series of scans.
Yes.
Were there any other factors that played into that decision?
Yeah, I think there were. Initially, well, even prior to getting that sort of information, I was always under the impression if I did get that sort of information, depending on what age I was, I would deal with it maybe differently. But when you're moving on and you're into your early 80s, you start to think of things differently. And I could have been excused for saying, well, is it worthwhile going ahead? Let's run with it. Let's see how it goes. And if I get 3 or 4 years, I may get something else wrong with me. So behind all that was this fear of an operation probably. So let's avoid it if we possibly can. I had a situation where for 2 years I'd been the full-time carer for my wife. By the time I met you, she'd started with dementia. So she'd started to forget about the cancer, fortunately. But it became more and more a full-time job. So there's no way that I wanted to have surgery that I could avoid temporarily as I was a full-time carer. It was something that you wouldn't probably talk about, the emotional side of it and that sort of thing. But that was important. I mean, there was no way I could have actually risked being laid up during that period.
Because we watched the tumour for about 18 months, didn't we? And then, as you know, the scans showed that there was progression, although it was slow.
Yes.
And I said to you, look, it is growing, so there's a slightly higher chance that it's a cancerous thing. And at that point, you opted to have a biopsy. What was it that Mr. Mann told you, or how did you reach that decision then to just keep an eye on it?
He told me from what he knew I was fit enough to have the operation.
Yeah,
go ahead and do it.
Certainly are, aren't you? I mean, you're fabulous.
I think so. But there again, he did say it was growing slowly, and because of the other aspects of my wife, and where I was getting more demanding, he could accept the fact that I would put it off again. He didn't say put it off again, but he didn't sort of say, I'm sorry, Brian, but you can't put it off, we've got to go for it.
What would you have said if either myself or Mr. Mann had said to you, come on, Brian, I really think you need to get this sorted now? I mean, would you have felt that that would be a reasonable thing to do, or would you have seen that as being perhaps taking away a bit of the autonomy?
I'd have done it. I'd have wanted to know roughly, with a fair wind following, how long I'd be laid up for, and then I would have paid to get support in from my wife and get on with it.
Okay.
But I wouldn't have wanted to go down that route.
So it might have been us perhaps pushing you slightly against your intuition.
Yeah, you'd have had to push hard for me to go do it, but no, I would have listened to you, as I always have.
I mean, I guess there comes a time sometimes where there isn't a right or wrong answer. So how do you deal with that situation?
I mean, I'm 83 years old, so I'm not getting younger. I'm going to pop it at some stage or other. It's going to be sooner rather than later, possibly. So there is that aspect to it. You've got to be a realist. But on the other hand, it wants doing, and as long as you couldn't sort of say whether it's going to be successful or not, but as long as there was a reasonable chance it could be, and it was not a tremendously long recovery, and unlike with some procedures, you finish up being more poorly than you would have been if you hadn't had it. Many people go through losing a kidney for one reason or another, and I think I could cope with that, and I would say let's get on with it. We're where we are, aren't we? I mean, if I was 60, it would be totally different. If I was 40, it would be different even more. But the circumstances were slightly different. I'd got a series of situations coming along health-wise, and I was trying desperately to clear the deck one after another, but the damn things kept coming down the track. So, and equally, I couldn't get out of the fact that I was looking after my wife, and fortunately, managed to keep her at home right till the bitter end. So I don't regret, whatever the outcome is now, I don't regret having put it off during that period of time. If it had been put off just to have a bit of a jolly for a couple of years, I would have said to myself, you've been rather silly here, you should have had it done. But as it is, I did it for the right reason. Whatever the outcome is, those were the right reasons. There is sometimes more to it than a consultant just proceeding forward from a medical side and not trying to find out what's under the surface. I know you haven't got time to do that in every case, but in some cases, there may be something under the surface which would alter your interpretation of the patient's decision making.
And just thank you again.
Thank you for all your time.
You know, for taking the time to come and talk to us, and I'm sure that we can all learn a lot from what you've said.
Good luck at the conference.
Thank you, Brian.
I think Brian deserves a round of applause. Look, I think you'll agree that Brian's a fantastically engaging, charming and eloquent individual and has stated, you know, his case really well there. I'm really humbled that he chose to come and talk to us, particularly as he lost his wife 3 weeks before we recorded that interview, and in fact the funeral was just a few days before that actually, and obviously I gave him the option to call it all off, but he was really insistent that he wanted to carry on and do it. So what can we learn? I think as surgeons, this is what we're comfortable with, isn't it? Diagnosis, surgery, cure. This is what we're trained to do. This is what most of us like to think we're reasonably good at. This is what we feel much less comfortable with, going from diagnosis to non-operatively managing a patient and, you know, leading them through the remainder of the time they've got less. But remember, the final common pathway is the same here, isn't it? And particularly in the elderly population, the interval between the top box and the bottom box may not be that distant. And I think it's understanding and respecting that and putting it into context of the patient's other priorities. And you know, this was, I got lost in the middle of Glasgow yesterday, actually, because I went for a sneaky coffee before I came in yesterday morning. So, you know, Google Maps gives me several different routes to get to the SECC, and I have got the worst sense of direction in the world, admittedly. But look, you know, our jobs as surgeons is to make sure that we acknowledge that there is more than one route, and the patient's in control. We may not always understand why they want to go at a slower pace. We may not understand why they might want to go the scenic route by the river, but we owe it to them to allow them the opportunity to choose, I think. Our job is to provide the information, make sure that information's up to date, make sure we know where the roadworks are, make sure we haven't accidentally got ferry trip across the Clyde on the way to the SECC, but ultimately we have to respect the patient's right to change their destination halfway through. Now, there are clearly challenges with this approach. I'm sure we've all been faced with these situations, you know, patient that subcontracts the entire decision-making to you. You're the doctor, tell me what to do. The one that wants to bury her head in the sand, don't tell me about the risks, I'm terrified, just get on with it, do what you have to. Where I work in Nottingham, that's a really common scenario. Perhaps the trickiest one is the third one, where there's conflict amongst the family and, you know, even amongst the other healthcare professionals that we work with. And, you know, it's not uncommon that, you know, the patient's wheeled in by a very demanding relative. My mum's being silly, she doesn't want the operation. Come on, doctor, tell her she needs it. I'm hoping that our next speaker, Dr. Coulter, is going to tell me how to deal with all these situations. But thank you very much for listening to, well, a little bit to me, but mainly to Brian. And I'll hand over to Angela.
So Brian's video was wonderful, wasn't it? And it almost made me feel I don't need to get up and say anything because he said it all. But my major research interest is into how we can help patients make difficult decisions. And so I want to show you some of the evidence underpinning what Brian said. First of all, and I think what we've all been saying, and I take it from your responses to the questions, you're all on board with this. We know that clinicians have a huge body of expertise summarized here, but the reason that patients increasingly are being involved in decisions is because patients also have a body of expertise that may not be so accessible to the clinician. So the aim of a good medical decision is to share these two bodies of expertise. The patient, and only the patient, knows what it's like to experience the condition, or in the case of the examples you've heard today, number of conditions and other issues in their own social circumstances. They, and only they, know about their attitudes to risk, their values, and their preferences. So the aim should be to bring all those things into the decision-making process. And this is what is known as shared decision-making. It seems to be a term that's on everybody's lips these days, but it's still not as widely practiced as we might want. The GMC tells you to do it. Even the Supreme Court in the Montgomery judgment also tells you to do it. But when we look at the figures, these are the figures from the NHS patient surveys in England, which are massive surveys done every year. This is the inpatient survey. You can see that only just about half of patients actually are involved currently in decisions about their care as much as they'd like to be. I had a quick look at the Scottish data yesterday, and that shows more or less similar thing. So although there seems to be a desire to do it, it's not happening as much as patients would like. And one of the reasons is because actually it's quite tricky to do. If you're going to do shared decision making, you really need to think about three aspects. First of all, information. Brian clearly was well informed by Harry, but he also stressed the need for information that was written down. He explained why it was difficult sometimes to remember everything that you're told in the somewhat stressful environment of a medical clinic. So ideally you want a good conversation with the clinician, but you also want supporting information that you can look at when you go home. Now, often that information may be on paper, but there's a real problem with paper information in that it goes out of date. And what patients want is evidence-based information. They want it well and clearly presented, but it should be based on the evidence. So increasingly these days, we're seeing this information presented online. Sometimes, and perhaps this is the ideal, with an option to print it out so that it can be printed out and the patient can take it home, or they can look at it on their smartphone. So you need good information, and I'll say a bit more about that in a second. You also need a good conversation to help the patient work with the clinician to make a joint decision. And often, and in most of the examples we've heard about, those decisions are really quite difficult, and they involve a number of factors. So that supportive role that the clinician needs to play with the patient is really key. And finally, of course, we need a commitment to implementing the joint decision that is made following that kind of period of deliberation. The Academy of Medical Royal Colleges is using this BRAN acronym to summarize what's needed. Information about the benefits of the treatment that's under consideration, information about the risks. That does not mean a very long list of every possible side effect. It means balanced, evidence-based information, the main issues that the patient needs to think about. Alternatives, and again, the Supreme Court underlined this, that you need to know not just about one treatment, but what happens if you don't choose that treatment? What other treatments might achieve a beneficial effect? And finally, treatment itself, as in the case of some of the patients you heard from, may not be the desired option. So patients want to know, what happens if I don't opt for treatment at all? Now, we know quite a lot now about how to communicate risk. Communicating risk is difficult, and it's particularly difficult when you're talking to people who may have no background in understanding advanced mathematics or statistics or the science of probability. But we do know that it is possible to get these issues across if you use a carefully designed approach. We know that numbers are better than words, that it's people can sort of grasp numbers. One person's rare event is somebody else's quite common event. So the words need to be backed up by numbers. We know, I won't go through all of this, we know that graphics can help, and I'll give you an example of that. And we also know that it's terribly important to underline uncertainty, to make it clear that you can't say with any definite, or rarely anyway, you can't say definitively what's going to happen to this particular patient in front of you. Now here's an example, it will be very familiar I think to most of you, a sort of Kate's plot or a smiley faces plot. This one happens to be about statins. I should apologize for the fact that although there has actually been quite a lot of research in urology, particularly into things like PSA testing, BPH and prostate cancer, into how to use shared decision-making in those cases. It's trickier when it comes to more complex cases, as I shall show. But anyway, these Kate's plots have been well used, and we know that they can help people, particularly when used in a clinical discussion, help people understand. Many of the decision aids for patients that have been developed also include elements which are designed to help patients weigh up their values. And this is an example from breast cancer. It's actually a computerized one. And so the patient ticks the issues that are most important to her in this case, and the scales kind of tip. And this just gives both the patient and the clinician an idea. These are women who are choosing between lumpectomy plus radiotherapy versus mastectomy. It gives both of them an idea about which way the scales are tipping in view of her particular concerns and values. Video has been shown to be very helpful. There's a team in the States led by somebody called Angelo Volandis who's done a lot of work, particularly in end-of-life care, a number of trials looking at what happens when you illustrate future possible options using simple, very short, 2 or 3 minute videos. And this one shows, this was for patients with advanced cancer, just trying to help them decide whether they would want CPR if it came to it. And you can see that when they got just a verbal explanation, the two groups before and after in the trial were more or less evenly balanced. But when they got the same verbal explanation plus a video showing what it was like to have CPR, the decisions changed quite dramatically in favor of no CPR. Now, there are lots of trials in this area, and a Cochrane review, this happens to be one of the most highly accessed Cochrane reviews in all the Cochrane library, summarizes the evidence when it comes to using these kinds of information packages with patients. There's no doubt about it that you can increase patients' knowledge and understanding. You can help them come to more accurate calculations of the risks that they would face, either with or without treatment, comparing the options, etc. These patient decision aids help them participate more actively in decisions, make them feel more comfortable with the decisions they make, and very importantly, they increase the congruence, the agreement between patients' own values and the treatments that they subsequently undertake. Now, it does get more complicated, as you've heard, in the last year of life or when you're dealing with potentially life-threatening conditions. And there has also been quite a bit of research into what patients need, what kind of support and information they need here too. We know that most patients do want to be involved in decisions, they do want information, and they do want their family to be involved too. That's the majority. But there's also an important minority who don't necessarily want all those things. Some really don't want much information. Some don't want to participate actively, particularly if it's a decision that might impact on their life expectancy. And some don't want their families involved. There is no way you can judge what they want just by looking at them. So that points to the need for a really good discussion about patients' decisional needs. What level of involvement do they want? Now, most people want information, even if they don't want to be involved in the actual choice of treatment. This is a model of the kind of decisions that need to be made. And of course, it's much like all models, it's much too linear and much too simple. It's not as straightforward as this, but it sometimes helps to unpack the issues. So patient comes into a medical consultation with a set of initial preferences. And the first thing that must be done is this discussion about, to try and gauge what role they want to play. You know, do they want to be involved in the choice of treatment? What level of information do they want? What level of sophistication do they have? Do they, are they likely to need quite a lot of help in understanding the information or not? And then there's a discussion about the options, and that does have to include all the options that I mentioned, the alternative treatments, and what happens if I don't have any treatment. And then finally, the clinician and the patient come together to make a joint decision. Now, this is definitely not about abdicating all decision-making to the patient. This is very much about shared decisions, shared discussions, sharing expectations. Now, it gets even more complicated, like everything else, in conditions of multimorbidity. A lot of this research, as is the case right across clinical research, has focused on very discrete decisions for single conditions. And it's a problem we have. What happens when, as in Brian's case, you have more than one problem? An interesting letter to the Lancet, and it was no more than that last year, described a way that some clinicians have worked out to deal with this. And the sharing bit, the first bit, they call this Sherpa, I'm not quite sure why, but the sharing bit is about discussing the patient's life and the conditions that they have, understanding that, including things like the burden of treatment. Then the clinician helps the patient to link all these things, often by drawing pictures. So this is not relying on pre-designed information packages, this is creating the information package. And then together, once the patient has, using the pictures, has indicated which are their main priorities, in Brian's case it was looking after his wife with dementia, which of their main priorities did they need help with, and what might fit, and where would you start? Now, this is really called personalised care planning, and I led a Cochrane review a couple of years back, where we looked for trials that had evaluated the impact of this approach. We found 19 RCTs involving more than 10,000 participants, and the news is good, pretty good. I mean, the evidence wasn't all very clear, and the trials weren't all the best quality, but we found that if you adopt this kind of approach, you can help to, or it leads to, improved physical health, improved emotional health, and it improves patients' capacity to self-manage their condition and their various other problems. So in summary, what am I saying? I'm saying that I think it's really important to try to get an assessment of patients' decision support needs, and I'm not suggesting that's easy. That does depend on a very good conversation and a very good understanding, and it's easier, of course, if you've had a long-term relationship with the patient. Then you've got to provide relevant evidence-based information and help patients to understand it and check their understanding. And again, it helps if some of that is written down so that the patient can review it and think about it. And then you've got to elicit patients' goals and preferences, work out what's really important to them, which of the things are less important, and then together plan their treatment or their management or their support needs. Thank you.
Thank you to all the speakers. Unfortunately, I don't think we have time for questions, but I hope this has given food for thought and we can all go and just take that bit more time with our patients and listen and work together. Thank you.